All right, good afternoon. Welcome back from lunch. I hope everybody's had a good time with their lunch session. We have a really exciting set of speakers lined up here this afternoon. I'm Chris Love. I'm a faculty member in the Koch Institute, and it's my pleasure to introduce to you David Hunter. David's the Vincent L. Gregory Professor of Cancer Prevention, Acting Dean of the Faculty and Dean of Academic Affairs at the Harvard T.H. Chan School of Public Health. He's highly regarded in his research in the etiology of cancer, and today we're going to get to hear his thoughts on the preventable fraction of cancers worldwide. David.
Thank you. So thank you, Chris, and I'd like to thank Nancy and Ed for the invitation to talk today, and thank Tyler and the Koch Institute for having the wisdom to make this the topic of the annual symposium. What I'll be talking about is how we can take epidemiologic data and calculate how much cancer we can prevent, not just cancer incidence, but also cancer mortality. Let me just lay out some of the dimensions of the problem. So basically, these are estimates of numbers of cancer deaths as we proceed to the year 2030, and you can see a steep increase in cancers overall. This is the line for so-called less developed countries. This is the line for developed countries. So we are going to see some excess of cancer in developed countries as time goes by, but already most cancers in the world, Dr. Badia talked about this earlier, occur in the less developed world, and the rate of increase is much faster. So why is that? You might think it's because the rate of increase of things like smoking is much faster, but it turns out to be just essentially simple demography. So here is the estimated number of people in the world in the past and going out to 2050, and we're still in the steep part of the curve of population growth. Population is expected to increase from about 7 billion to 9 billion in the next 30 years. So more people, more cancer. This is where the growth is happening. So the red is the areas of the world with most rapid increases in population. The brown is where the increases in population are still substantial, above replacement. The blue is where increases in population are below replacement. So you can see in China, one-child policy, actually reductions in the rate of growth of population combined with people moving from rural to urban areas. Most of the population growth is occurring in South Asia with intense hotspots in Africa, less growth in Europe. But these are the areas of the world that are least able to diagnose and treat cancer in a modern way. So one of the big problems we have is that we've got increasing numbers of cancers, but they're also increasing faster in parts of the world that are less equipped to at least treat the problem. The other part of the demographic driver of increased cancer numbers is the aging of populations. So in the color, men on the left, women on the right, this is the age distribution by 5-year interval in China in 2010, and the open bars are the estimates for 2030. And so the bulge right now in sort of early middle life is going to move into earlier old age, and since most cancers increase as a function of age, the number of people who are in those older age groups who are going to be diagnosed with cancer will almost inevitably increase. And just to make it a little more complex, the type of cancers we are dealing with around the world vary substantially from continent to continent. So here are data by level of the Human Development Index. High in blue are the developed countries, red, the least developed countries. Most people in the world, or the biggest single group of people in the world, are now in the orange countries that have a medium development index, Human Development Index. And in our countries here, top cancers are colorectum, lung, breast. But in the rest of the world, where most of the people are, we're talking lung, stomach, liver. So the types of cancers that we have to try and prevent, the types of cancers that we have to diagnose and treat if they occur, vary radically around the world. So you often hear the phrase, half of cancer is preventable, and the next question is, well, are we talking about preventing cancers? Are we talking about preventing cancer mortality, cancer deaths? I'm also very interested in the question how much mortality is preventable with greater access to what are standard treatments in developed countries. I'm not talking about the latest targeted therapy. I'm talking about variations on standard diagnosis, surgery, maybe chemotherapy or radiotherapy that has been established practice for decades in developed countries. So I'll be talking a little bit about an epidemiologic concept called population attributable risk. So the population attributable risk for any risk factor is essentially how much of the cancer is due to that risk factor, or you can ask it the other way around, how much of the disease would disappear if the risk factor was eliminated. So this is a combination of both the size of the risk associated with a risk factor and the prevalence or proportion of the population that is exposed to that risk. So if you have a small risk factor with a relatively rare exposure, that's going to have a very low population attributable risk. It's not explaining many of the cancers in a population. At the other extreme, if you have a large risk that's common, then that is going to be associated with a high population attributable risk. For small, rare, you could think BRCA1, for instance. Large, rare, you could think of BRCA1, for instance, and that'll have a low population attributable risk. Large risk, common exposure, think of smoking. Relative risk for lung cancer among smokers lifetime is over 20-fold. And unfortunately, it's a very common exposure, so it's got a very high population attributable risk. So I just wanted to show some unpublished data on how this works for breast cancer, because I think it's sort of illuminating, certainly in our own context. These are some analyses led by Rula Tamimi in the Nurses' Health Study, a long-running cohort of women that's been going since 1976. 121,700 women enrolled in 1976, and over time up till 2010, over 8,000 cases of postmenopausal breast cancer have occurred. Risk factors for premenopausal and postmenopausal breast cancer are somewhat different, so we just focused here on the more common postmenopausal breast cancer. We grouped the risk factors into two categories: those that are modifiable, so in theory, a woman in middle life has some control over these, people may argue, such as weight gain, alcohol consumption, physical activity, duration of breastfeeding. That's something that once a woman's menopausal isn't going to be modifiable, but it's a modifiable risk factor prior to that, and menopausal hormone therapy. Non-modifiable risk factors unambiguously are things like family history of breast disease, can't change your family history, prior benign breast disease, and by middle life, you can't change the body mass index you had at age 18. And there's a whole series then of other risk factors: age at menarche, age at which a woman gets her first period, age at first birth, number of children, parity. So these vary a lot between different populations. The areas of the world where women still have an average of 6 children, areas of the world where it's 2 or less. So it does vary over countries and continents, but these are not things that a woman in middle life can vary. So they're non-modifiable in that sense, although you could imagine they're modifiable, and they do explain quite a lot of the difference between cancer rates or breast cancer rates in different countries. So looking at the non-modifiable risk factors first, this is the population attributable risk. So again, if all women were in the low risk category for age at first period, that's late age at first period, then we'd have 8.6% less breast cancer. And on you go down, so about 55% of breast cancer can be explained on the basis of not being in the low risk category of all of these risk factors. The problem is that, again, once in middle life, it's too late to change these particular risk factors. So they're not modifiable, they're non-modifiable. But it's important to make the distinction between the amount of cancer we can explain and the amount of cancer we can prevent, because there's two types of risk factors: the factors that are unambiguously risk factors but can't be changed, and there's the factors that could be changed. So looking at the modifiable risk factors, we estimate about 35% of breast cancer postmenopausally due to things that could be modified, mainly weight gain and postmenopausal hormone use, a little bit for alcohol, in our hands, not much for physical activity, and breastfeeding. This wasn't a population where long durations of breastfeeding, which is probably what you need to be getting some lower risk of breast cancer. So you probably need several years of breastfeeding over multiple children to get a big impact, and here the impact is low because the prevalence of those long durations of breastfeeding are low. So put it together, over 70% of postmenopausal breast cancer can be explained by risk factors that we know about, but only approximately 1/3 is preventable. As a technical note, that's slightly higher for estrogen receptor positive disease than estrogen receptor negative disease. So even with maximum prevention, things we could advise women shortly before menopause or at menopause to make certain lifestyle changes, theoretically we could prevent 1/3 of postmenopausal breast cancer, but we'd still be stuck with the 2/3. And so that's where you need treatment to reduce premature mortality. And it's always, I think, important to acknowledge that much as we want to prevent incident cancers, cancers will occur, so we want to be in a good position to be able to treat and prevent mortality from those cancers. A lot of excitement about the germline inherited variants that are associated with breast cancer risk. We now have not yet published, not yet even submitted, I think, but we have 170 germline variants at various points across the genome that are unambiguously associated with breast cancer risk. But the risks for those germline variants are all very low. These aren't BRCA1 mutations with a 20-fold excess risk at young age. These are germline variants that convey a 10 or 20% increase in risk as opposed to the 2,000% for BRCA1. But once you have a whole lot of these and you put them together, the Mendelian play of chance is that some women will have inherited rather more of the risk alleles, some women will have inherited rather less. And so this is just recently published in JAMA Oncology from Paige Maas and Nilanjan Chatterjee, putting together data from 17,000 cases, about 20,000 controls, looking at the risk factors, just as I did before, modifiable, non-modifiable, and then putting together a polygenic risk score, which essentially means just adding up all of the adverse alleles based on the first 92 SNPs that were known. So when you just look at the polygenic risk score, you can develop these risk predictions for cumulative risk of breast cancer according to whether a woman carries more or less of these adverse alleles. And if you just look not at the 99th versus the 1st percentile, but if you look at the 95th versus the 5th percentile, this is actually about a 6-fold variation in risk. And here are the here are the cumulative incidence over 10 years estimates, again about 6-fold for women in the 5% with most alleles versus the 5% with fewest alleles. So that's about 10% of the population that we're comparing. And I show this just because, based on this morning's discussion, it's likely that women at higher risk would be more likely to benefit from breast cancer screening if the breast cancer screening is effective, because they're more likely to develop breast cancer, and a positive test is more likely to mean breast cancer. So it's possible, once we're all sequenced and the information is essentially available in our medical record for free, that we may find that this information may be used to stratify the age at which a woman is recommended to start mammography, maybe have a different frequency of mammography. And this applies to pretty much all of the major tumors now. We have this sort of information where just based on a DNA sample and germline variants, we can get substantially different predictions about lifetime risk. The other question is, well, how does this play off against the modifiable risk factors? And so these are data from the Maas and Chatterjee paper. So if you break into 5 categories, risk of non-modifiable inherited risk, so this is low and this is high, and then you look, similar to what I did before, at the modifiable risk factors, they came up with 33% of breast cancer due to the modifiable risk factors, so not too far off the 35% that I showed you. But because the relative risk is the same across the different strata of inherited risk, more of those cases are going to be clustered in the higher risk category because you're increasing by a fixed amount from a higher baseline versus a lower baseline. So about 30% of the preventable cases occur in the top 20% of risk, and about 12% occur in the bottom quintile. So one view of this is, well, the recommendations are going to be the same for every woman, and so this really doesn't make much difference. Another way of looking at this is over time, particularly if the information is available for free, then this can be used to specifically target preventive advice to women at lower or higher risk. And that's where, across a broad swathe of cancers, the genetics combined with the epidemiology seem to be going. So in summary, relative risks are extreme, substantial in extremes of the polygenic risk score. Rumors of the futility of GWAS, I think, were greatly exaggerated. There may be clinical relevance if you're in the extremes. I'd also just point out, here's 170 loci that offer clues to breast cancer mechanism of causation that we didn't have 7 or 8 years ago prior to the genome-wide association studies. So now, how much of cancer in the world, going to the global scale, can we prevent? So here are the most common cancers in the world: lung, stomach, liver. And just off the top, we know that most of lung is caused by smoking. A very big chunk of stomach is caused by Helicobacter pylori infection. That can be treated and eradicated with antibiotics. And a big chunk of liver is due to hepatitis B, hepatitis C as well, combined in certain areas of the world with aflatoxin exposure. And of course, I'd be remiss if I didn't point out that much of the work on aflatoxin and liver cancer was done here at MIT by Jerry Wogan and colleagues, and that's had a major feedback effect on areas of the world where aflatoxin, a mold growing in cereal crops, can be reduced just by better storage of those cereal crops. So just looking at that, you can see that a big chunk of cancer deaths should be preventable if we did the right thing. So looking a little more rigorously here, taking the unambiguous risk factors, not the speculative risk factors, taking factors for which an intervention is available through education, policy, vaccines, et cetera, and not taking factors that are completely infeasible or would be unacceptable, such as delaying a woman's age at menarche or prophylactic surgery for everybody. Just looking at what is actually feasible, achievable, where there's proof of principle. Here are the numbers of cancers in the world that occur according to cancer sites. So this is lung, this is breast, this is colorectum, and then just asking the question, well, what would we see if we could abolish smoking in red here? So big falls in the smoking-related cancers: bladder, larynx, lung, et cetera. No falls in cancers that haven't been linked to smoking. So adding this up, we'd get about 21% less cancer in the world if we could wave a wand and abolish smoking and wait the latency period that it would take. Another way of putting it, if we'd abolished smoking 30 years ago, we'd have 21% less cancers in the world. Looking at infections, again, focused here on HPV cervical, liver cancer, where hepatitis B vaccination, and as one of the speakers pointed out this morning, hepatitis C can now be treated. Stomach cancer with Helicobacter pylori eradication, but again, not including infections that we don't have a good intervention for or a vaccine for, like Epstein-Barr virus or HTLV1. That gets us about another 10%. So just two factors alone, smoking and infections, we could reduce the number of cancers in the world by 30%. And then just quickly running through reducing obesity, aspects of diet, reducing melanoma due to ultraviolet, and alcohol reduction and low physical activity. Pretty quickly, you can get to about 40% of cancers would be preventable if everybody in the world was in the low-risk category for those exposures. This doesn't include cancers due to occupation. The estimates are that that's a couple of percent. It varies widely around the world as the dirty industries move out of the developed world into the developing world. Air pollution, almost certainly the cause of some lung cancers in particular, but the epidemiology there isn't that great. And none of this includes reductions due to screening, for instance, for colorectal cancer. So if you throw these things in and you throw in screening, you can easily get over 80% of the world, 50% of cancers in the world are preventable if everybody got screened for the things that work and all of those lifestyle reductions took place. So some of the limitations on this sort of analysis don't take to the bank the deltas between the different exposures. So for instance, the 4% reduction in risk attributable to diet would be greater if diet had an impact on smoking-related cancers and we didn't do anything about smoking. So if you do it sequentially, you generate different estimates just depending on which risk factor you pull out of the world first. The latencies are substantial, so in my mind, that's why it's so urgent to get on with this stuff, because as was pointed out again this morning, cancer is a many-decade process, and if these things are initiating cancers, it'll be many decades before the effect of the interventions is fully felt. The other thing that's most particular to diet is most of our information is available on studies of adults. And a lot of people who work on nutritional epidemiology think that, in fact, most of the action is happening in childhood and adolescence and young adulthood. And so it may be more important to change diet at those ages, but we just don't have the data. And finally, this only applies to the top 27 cancer sites. So there are some cancers that aren't factored into the equation. Looking at mortality very quickly, high incidence tends to be higher mortality, but the mortality incidence ratio varies widely around the world, depending presumably on the effectiveness of things like screening and treatment. So a thought-of experiment is, what if all countries in the world for each cancer had the mortality to incidence rate that applies to, let's say, North America? So here's North America. There's about threefold more cancers diagnosed than there are cancer deaths, as opposed to some other areas of the world where a much higher fraction of the diagnoses are translate into mortality. We can discuss the sort of potential surveillance biases, but a big factor here is that these are parts of the world where you just can't get your cancer treated. So if treatment does anything, it's not going to do anything in those countries. Just to reinforce the point that was made earlier, some of the biggest disparities in global health apply to cancer treatment. So this is a figure of the number of radiotherapy units around the world. So in this country, about 3,500 in red. These are countries that don't have a single radiotherapy unit. And per head of population, more than a tenfold difference between the countries in green and countries like India. So it's much, much harder to get access to treatment, even relatively low-cost treatments like radiotherapy in much of the world. So we run the calculations, and we get about a 27%, let's call it 30% reduction in cancer deaths if everybody, in theory, got the same ability to get diagnosis and treatment that we do have in the US. So we can't treat our way out of this, even with the best of modern medicine, excluding maybe targeted therapies to come. There's still going to be a lot of deaths, although there's a lot of preventable deaths once cancer is diagnosed. If we go back and ask the question, how many cancer deaths are preventable by the abolition of smoking, vaccination for the infections, and the other things I showed you. That actually turns out to be about 50%. So 50% of deaths could be prevented, and the reason is that some of the smoking and infection-related cancers like lung and liver are particularly nasty and hard to treat, and so you prevent more deaths by not getting those highly fatal cancers than some of the other cancers that are a little more lingering, indolent, or more easily treatable. And put the two together, we could prevent over 60% of cancer deaths by a combination of risk factor reduction and mortality reduction. So I think I said all of that, 50% of cancer deaths preventable through risk factor reduction, and another 30% if we extended modern care detection, 60% in total. So in summary, the cancer burden is growing very fast. Unfortunately, cancer is much, much more complicated than rolling out HIV medication for treatment of HIV, or even dealing with most cardiovascular disease or diabetes, because there's so many different types of cancers and so many different modalities of both detection and treatment. So it's inherently more complex. But we need to remember a cancer prevented is a cancer that doesn't have to be treated. So prevention needs to take a really center stage. And we really need help from people at MIT to devise new solutions to help increase and monitor smoking cessation, greater access to vaccines, drugs, obesity prevention. We do need to remember, though, that even with maximum prevention, there will still be a very large number of cases due to the non-modifiable and unknown risk factors. And so that's where we need new solutions from MIT for screening and treatment, lower cost pathologic diagnoses. A lot of people can't even get a diagnosis of their cancer. Lower cost surgery, chemotherapy, and radiotherapy, and health systems and workforce development are needed around the world to incorporate this new knowledge to both prevent and treat cancer. With that, I will just acknowledge some of my colleagues, notably Rula Tamimi, Donna Spiegelman for the population attributable risk estimates in breast cancer, and a wide variety of colleagues working on the NCI Breast and Prostate Cancer Cohort Consortium for the data on germline SNPs. Thank you very much.